Welcome to Stay on Track podcast with Poolson Oden Law Firm. Danny Poolson, along with my amazing co-host Carissa Oden. Our vision is to help 500 plus families battling injuries by year 2028.
Our motto is that we help people who are hurt. Our goal is to earn each client's trust by showing up for them every day. When we say PO in our office, we think protecting others. We started this podcast to share knowledge, experience, and insights free of charge to better spread our vision and serve our communities near and far.
Today we're airing episode 8 of Stay on Track podcast with Poolson Oden Law Firm. We're talking access to health care, what they're not telling us. And we have a very special guest with us today, Ashlee Schneider, Doctor of Pharmacy and Certified Specialty Pharmacist, who currently serves as the Strategic Account Manager for Walgreens Health Systems Division.
Yay.
What an intro.
Welcome, Ashlee.
Thanks for having me.
That was a mouthful. So what does a strategic account manager for Walgreens Health Systems Divisions do?
It's a great question. We account managers, so for health systems, our primary book of business or our client list are hospitals, health systems, FQHCs, community clinics, folks that we partner with either for contract pharmacy, for 340B, contract arrangements, any type of community service or like philanthropic events that we serve. We do a lot of interdisciplinary work with their clinician teams, like their physicians will have pharmacists integrated into those models. So basically anything that's done with that client through our partnership falls under me.
So when I think Walgreens and pharmacists, I think of white lab coat behind a counter serving medication.
That is accurate. That's primarily our retail model.
Okay.
So now we have specialty pharmacies throughout the community. So we've always had like a large mail order specialty pharmacy, which is typical of most chain pharmacies. But now we've moved into some models. We have like our health system on-site pharmacies, which are those that I'm referencing that are inside of hospitals. And we also have community specialty pharmacies where they're standalone pharmacies that just look a little different. They don't have the front-end convenience items, and they service primarily specialty patients. So patients with really complex disease states where those staff have additional training, clinical knowledge, expertise to make sure they can tailor the care to that patient population.
So in your current role, are you not standing behind the counter dispensing medications?
I am not.
Okay.
Did you used to do that?
Yes.
How long did you do that?
I started as a staff pharmacist in retail. And, you know, you talk about the Holy Spirit positioning you where you're supposed to be. I always thought I would end up in clinical pharmacy, which is the pharmacists that are employed by hospitals and health systems that work on the units and serve primarily like clinical needs. They help physicians like guide treatment plans and things. And I won't get into the weeds, but long story, you know, my path didn't lead me there. It led me to retail, which when I look back retrospectively, it's where I belonged. My strengths, my personality, you know, I belong in a fast-paced environment where I can touch as many people in a day, you know, as possible. So loved it, you know, started in it thinking maybe this wasn't where I fit, immediately knew that I was supposed to be there. And then I did retail for 4.5 years before I moved into specialty. And I did that as a staff pharmacist and then quickly got promoted to pharmacy manager of one of those stores and then promoted shortly thereafter to an operations manager, which is similar to a pharmacy manager but more tailored to the operations of the pharmacy in lieu of people management. So went from managing a lot of people to a lot of things, and then from there moved into account management. And I've been practicing almost 9 years now.
Do you miss being behind the counter?
Very much, yes. I think if there were more than 24 hours in a day, you know, I would do so many jobs. I joke about this all the time with my husband because, you know, there's so many parts of you that you want to access and you want to give back to as many areas where you can. So my role now, I'm doing so much behind the scenes that's serving patients, but I do miss, that the one-on-one, the personal, getting to know them and being that point of contact for them. I miss.
So going from clinical pharmacist to now being in more of a management role, operations, you have a wealth of knowledge to share with our viewers about health insurance and benefits and things like that.
Yes.
Okay. What
Can you share that?
Yes.
We all want to know.
My mind is like, where do I start?
Well, let's start. How about we start with some basics? Health insurance, what it
Okay,
is,
yes.
an overview, things
Yes.
like that.
First, I want to share why that became so important. So you get into pharmacy, you think, okay, you're going to counsel patients on all these new medications. You're going to make sure they're not interacting with one another. You're going to get their treatments and their disease states under control. And you're empowered with all the education you received and what you're going to be able to do to serve all these patients, right? And then you quickly realize that you can't do any of that if they can't afford it or if they don't show up to pick it up, right? So then all of a sudden access becomes goal one. So getting the medication in their hands is goal number one. And then I get to do all the fun clinician parts, right? I get to take care of them and maintain their care after that. So to think access was a barrier, that's not something that's taught in school. It's not something you hear about as much through the profession. So you learn it quickly if you start in retail that, a large percentage of your patients are not even getting access to the care. So with insurance, most patients are insured, whether it be through Medicare, Medicaid, or commercial insurance, which commercial can be like employer sponsored, or you can purchase it, independently. So what I saw mostly in the beginning of my career was commercial. So that was what I learned first. And then as I moved into an outpatient pharmacy in one of our public hospitals, I learned quickly the in and outs of Medicare and Medicaid as well. So they all operate in a similar way with different nuances. So we don't want to get too heavily into that. But the big thing is that the claims have multi-levels of approval before you're getting a payout. So it's not simple like you go to the drugstore and you pick out the gum you like and you see the cost on the gum, and so then you buy the gum and then you consume the gum or chew it and spit it out in theory. So it's not at all how healthcare works, right? So there's a big difference between medical and pharmacy, which I think we can get into in a little later. But medical benefit, it's not real-time processing of these claims. So when you go to the doctor, you receive a service, like you have a doctor's appointment or have a procedure or experience some sort of healthcare, and then they bill the insurance afterwards. So you don't know when you go in for that service what it's going to cost, right? They can estimate based on, most offices have like billing teams, folks that, have extra training in billing insurance and things. So they can estimate, but you're expected to know before you go, is that doctor in your network? Is that office in your network? Because believe it or not, you can see a doctor in multiple places and it not be covered at both places. Is the service a covered service? If it's not, is it medically necessary? And that's not based on your opinion. That's based on the opinion of your insurance company. And then if it is, what extra steps do I have to take to get it approved for coverage? All the while, you need to be doing vetting and doing all of this before you even go for the service or appointment, or could get blindsided.
Which sounds a little crazy, right? That the doctor that's telling you need something, there's another whole group of people that are trying to get paid that are saying you don't.
I think that's the biggest thing. And that's the hardest thing for patients to understand. In pharmacy, if they present with a prescription after going to a thorough and what they feel is appropriate appointment with their physician, and they present the prescription and the pharmacy says, oh, this requires a prior authorization, or this isn't on your formulary. So in specialty pharmacy, they're trained to start that process, to start the paperwork, to contact the insurance, to get the information they need to get it covered. But in retail pharmacy, not only is the training not there, the time isn't there, right? And they don't have the access to the providers that, say, an outpatient pharmacy would have to just hop in their EMR system and send a message to the doctor saying, hey, I need a couple pieces of information and a signature on this and whatnot. So it's most of the time the message is this isn't covered. So then the patient's wondering, well, I trust my physician and I trust his or her opinion of my disease, and now I'm angry because the final piece of this treatment plan was to receive this prescription today, right now, from you, and you're telling me I can't. And unfortunately, that's true. And so sometimes, and I'd say more often than not, if it is appropriate and medically necessary, we can get it covered. It takes time, right? You're not going to get that treatment today. But there are cases where we can't. So even though the physician believes it's the best treatment and the patient believes it's the best treatment, it needs to be changed or altered based on the formulary or decision of the insurer.
And you said the term EMR.
Oh, electronic medical records. So that's their, the system that hospitals use to, like when they scan your wristband or put in your notes.
And do you have maybe some tips or proactive measures that a patient could take to try and help avoid what sounds to be like a potential delay when they get to the counter to get their medication?
The only thing a patient can really do from a pharmacy benefit perspective would be to have a copy of their formulary, which is accessible through their insurance company. So if your insurance company has like a website, usually you can download it. If not, you can call the number on your insurance card and they can, email it to you, snail mail it to you, however is convenient for you to access it. But having that, and this is the point I want to stress, is if it's not on your formulary and you and your physician believe it's what's right, my recommendation would be to argue on behalf of that treatment and for lack of a better word, fight the good fight and just see what lands and try, because if that's what's best for you, the last thing you want is your health to be controlled by the payer. So fight. But if you know your formulary, which I'll tell you, your physician does not know, because your formulary is determined by your PBM, which is your pharmacy benefit manager. So not the same insurance that is covering your medical benefit. They contract out for pharmacy benefits. So it's a separate team who developed that list. And so when you go to your physician's office, they do not know what your formulary is. It depends on not only your insurance, but also the plan of that insurance. So we could all three have, Blue Cross Blue Shield, but we might all three have different formularies based on the plan. So they don't know. We tell them, again, retrospectively, like if we receive a prescription and we know there's an equivalent on the formulary, we would then recommend an equivalent change, right? Hey, it's same class, same process, same function, just a different one. And those are easier to handle. But if it's something that is a class of its own and the insurance, it's not on your formulary, probably due to cost or things of that nature, then we want to, do the required paperwork to get it covered so that you can have access to the medications that's best for you.
So it sounds like the concept, I have health insurance, behind the curtain, there's basically an algorithm, this formulary that kind of controls what is and isn't covered. Is it fair to say it like that?
For pharmacy, yes.
And is there a way to maybe address that algorithm on the front end when you're looking for health insurance? Whether you're an employer or someone looking to purchase private health insurance, is there a way to get the best formulary?
So sure, if you pay enough. Is it based on money?
Well,
sorry. Is that too forward?
Well,
that was a great question.
It is in a sense. So, nothing is not, I feel. But employers do have very limited control. So it depends on a variety of things. So if the employer contracts with a PBM, which they will because that's who controls pharmacy benefits, they can pick. There's a variety. There's our large ones OptumRx, Caremark, the ones you see all the time, Express Scripts. Those are our large kind of, they kind of dominate the market. But then we have some smaller third-party PBMs that are kind of coming in, offering a little more transparency and a little more control. And they're getting some of these employer contracts because they're offering that. So it's really up to the PBM how much they want to share. So do they want to give you the formulary ahead of time and let you review it and make adjustments, which will affect the rates? Or are they saying, no, we control that, you contracted with us, so we control this. You just pay your fees and let's keep it moving.
And is there, when I think of like medications or drugs, I think of FDA, right? The Food and Drug Administration, right? Mm-hmm. When it comes to the contracting of services, these PBMs, sort of, I think of it as almost like a middleman. Is there some body of authority or rules or something that monitors how those costs are being, I guess, accelerated or set out or laid out?
That's in the works. So there's a few legislation actions. This is where I'm really out of my comfort zone on the legal front. But a few things are in process, both at state level and federal level, to increase accountability for PBMs, to increase transparency for PBMs. You'll hear people say, there's a lack of transparency, and that is quite literally not only between the PBM and the insurance company, but also the PBM and the pharmacy, and thirdly, the PBM and the manufacturer. So there's rebates negotiated with manufacturers that determine how much of that they're going to squeeze, and then the rates between the insurance company and the PBM are not visible. So the insurance company or the employer is not necessarily can see what the PBM paid to the pharmacy or the manufacturer and what piece they're getting back. And then the pharmacies, they, it's real-time processing of claims. So we see what they paid in that moment, but then later they come back and bill the pharmacies what are called DIR fees. And those are, an algorithm unseen based on, certain metrics of the pharmacy, and then they take those fees from the pharmacies. So that's what results in a lot of claims that we, lose. The pharmacies are losing money on some claims, which people don't understand, but it's the PBMs that are coming back and taking fees that are having that claim go under. Because we can't charge the employer or the patient if we don't know about it in real time.
Yeah, I guess as a layperson, it seems complicated.
Super complicated.
Is that by design?
It's commonly referred to as needlessly complicated. Like you'll hear billing experts in medical offices say, I've been on the phone as a patient and as a mother, because I've already had to fight one of my daughter's claims, and she's 15 months old. So it feels so silly sometimes. But when I talk to them, they're like, oh, they want this, this, and this. I've never heard of that before. Like, these people are experts in this craft, and they're saying now insurance companies are asking for these random things, and they control it. So they can say, you know what, this year we're going to shrink the formulary, and we're going to require additional paperwork, and we're going to add on our fees, and they just can. Because if they get the contracts, then they get the contracts. But yes, a medical claim goes through like 9 reviews. So first, is this person a member? Then do they have this benefit? Is the provider in network? Is the service covered under their plan? You'd think that would be it. No. Well, was it medically necessary? So you went to a doctor in your network. You got a service that you knew was covered because you proactively checked your plan documents to make sure it was covered. But then the algorithm says, did they need it? And what they're pulling from is your historical claims data and what they have about you in the computer. And then if that doesn't spit out an answer, it goes to a human, and that human has their own review process to determine if it was medically necessary for you. By the way, you've already had the procedure. And then if all of that passes, then they pay a negotiated rate to the provider. So they're not even paying the total cost of care that the provider would be billing you. They're paying a portion of that, which they negotiated on the front end before the year began to get contracted. And that's negotiated on both sides, the provider and the insurance. So if you ever have seen a doctor that says, we're not taking your insurance next year, has anyone ever encountered that?
Yeah.
And you're like, what? You're my doctor. Well, they probably didn't want to stop taking your insurance. The insurance just made a change that they couldn't afford or are choosing not to afford. So then they pay the negotiated rate, and then you're left with the copay, deductible, coinsurance.
I have a silly question. Our insurance premiums that we pay to the insurance company, where does that money go?
It goes from you to the insurance company.
And then that is used to then pay the provider these negotiated rates?
If the service provider was covered and it was medically necessary for you, minus your costs, copay, coinsurance, and deductible. So yeah. It sounds like you understand it very well.
I think it sounds like I don't want to understand it. Wow. Okay.
Yeah, and then I would think that the doctors, I mean, I've had some friends and family in my life that, they have things that they need, right? Insurance company denies it. They go to get the medicine. They can't have it. The doctor has to do an appeal. Doctor doesn't want to do that, right? And then weeks go by, and they're back, unfortunately, yelling at the pharmacy, right? Like, I called and I talked to the doctor, and they're supposed to do these things, and it's like a terrible cycle, and then they don't get the medicine. Right?
I used to tell my teams that we're healthcare professionals are public servants. It gets missed a lot, right? Mm-hmm. They're heroes, and that is all true. And I have respect for providers, nurses, anyone who's working in healthcare is doing a job. But we're public servants, so what I used to tell my team was it's a thankless job. But when you lay your head down at night that you took care of that patient, what they're going to remember is that you took a really long time. But they left with drug in hand at the lowest cost possible, sometimes free, because my goal is always I want it as close to free as possible. And we know we did our best. So they don't know what's going on the back end. And so I think there is a call to action for providers, pharmacists, billing specialists to just kind of step up a little bit and fill those gaps for the patients. But they're, of course, being stretched by their employers' resources, the time. It takes so much time.
Right, it's got to be so hard. And I know in the news a lot right now, they've talked a lot about, like the weight loss drugs, the diabetes, for using them for diabetes as well. Well, what they're supposed to be, I guess,
what they were
originally.
made for, yeah.
And, patients that need those, but then go and,
there's a
pharmacy's
shortage.
like, there's a shortage, or hi, it's going to be $1,000 for that. And there's nothing you can do.
The formulary changed.
Right.
Yeah. Because the PBMs are not going to put it on their formulary if people are taking it for 90 reasons, and then they're paying for all of that. So they just take it off. It's exactly what happened, actually, to most of the patients you're referencing. First, we had the shortage, which was so patients who needed it couldn't get it. And then the manufacturer started catching up with production. And then everyone took it off the formulary, which took effect January 1st. So that's,
And when you say formulary, Ashley, just so listeners kind of understand, meaning like it's on a list for what your insurance will allow you to have as far as medications.
Correct.
And if it's not on there, you can say, hey, can I put it on there? And they're going to say no, right? Or you can pay more to get it on a formulary.
Sometimes, as the employer or the patient?
Just as the patient.
Okay,
They just
as
are
the patient.
normal
So
human.
There's a non-formulary approval process. So if, again, it's deemed medically necessary by your PBM, they'll approve it and pay for it, sometimes at a higher cost, depending on like the tier of the medication. Is it brand name only? The benefit with brand name only right now is that a lot of manufacturers offer like copay cards and financial assistance for commercial insured, and then they have like their own programs, patient assistance programs for the government insured, so Medicare and Medicaid patients. But to answer your question, it can get approved. It's saying the right things, including the right information. So if I'm personally doing your authorization paperwork, I'm first going to the insurance. A lot of times that's also available through their websites, what's required. It'll say to get approval, needs to have tried X medication, Y medication, Z medication. or needs to have lab value between range of Q and R. And then you have to get that information from their clinicians, from their providers, and then submit the information. And it's going to, there's somewhere I'm like, well, that's going to get approved because we meet it. The barrier hits when you read the requirements and you're like, oh no, this patient's lab value is a little bit outside of that range. Or they've tried 3, but not the 4th, but the 4th would be painfully inappropriate right now, given all these other factors. So then you could still, give it a go, give it a try. And again, it comes down to the person on the other side of the machine that receives the document, and they're making the decision whether or not they're going to pay for it for you. So I don't want to spend too much time harping on how broken the system is, right? Because we could talk about that for hours, right? We could stay here all day and talk about that. But I think a couple takeaways that patients might want to know if they're wondering, well, what can I do? Because this feels like a lot of information. It doesn't seem like I'm controlling much. I'm a big advocate for control the controllables. And if you can't control it, let it go, right? Because that's life. So what you can control is preparation. So if you're going to a provider or to receive a service, the things we mentioned, is it covered? Is it in your network? If it's in your network, what tier is it? Didn't mention that earlier, but that matters. So you can have tier 1, tier 2, tier 3, and those increase the cost responsibility for the patient. So you want it to be tier 1, in network, service covered, and then at that point, the medical necessity piece, there's really nothing you can do to prepare for that, aside from, making sure your care team is doing what you feel is best for you, in an appropriate, care management setting. And then for pharmacy, you can have access to your formulary, but I would say ask more questions when you're getting prescribed a new medication, meaning ask the provider why they're choosing that medication. I can't tell you how many examples, I've been at lunch with friends and I'm telling them about, oh, I helped this patient get an approval for this, so on and so forth. And they say, well, no one knows to do that. And I'm like, you're right. No one knows to do that. So I'm thinking we've got this formula figured out to get some coverage and to beat the system in a way that it might not have been designed. But then you remember people don't know what to ask. So it's, what do you ask? Well, ask why they're prescribing it. Have the formulary with you. If it's off the formulary, tell them, okay, here's my formulary. Have I tried any of these? Do you think one of these would be equally appropriate? Because if you're having the conversation in real time, you're more likely to have, more value versus going to the pharmacy and then doing everything, retrospectively. It takes much more time. And then advocate. So if, we call it the AA, it helps you remember it because it's like the battery. Ask and advocate, always. So ask the questions. And if you don't know what to ask what the question is. Don't be afraid to say, I don't know what to ask you, but I need to know if this is going to be covered, right? Just help. And they'll probably refer you to their billing specialist because, believe it or not, your provider probably has no idea. Their job is to take care of you, your wellness, your body, your disease, etc. But ask, do you have a billing specialist? Can I talk to her real quick? And then at the pharmacy, same thing. If they say it's not formulary, say, okay, well, is your staff going to start the paperwork, or do I need to reach out to the doctor? Do I need to call my insurance? What do I need to do next? Don't just leave feeling like the system beat you, because there are so many things you can do. And then if it does get denied, which we're hoping that majority don't, if you get the right people and ask the right questions, hopefully you can get the coverage you need. But if you don't, there's external resources available. So there's patient assistance programs through the manufacturers of the products. They have foundations. I can't tell you how many patients I enroll in foundation care, even if it's covered and it's just an unaffordable cost. So you have patients, I won't get into it, but Medicare patients hit what's called a donut hole, which is basically the maximum amount that Medicare will pay before you're 100% responsible for the cost of your care. So they hit the donut hole, which they call it. And for the rest of that calendar year, they have to pay, $400 or $500 for these prescriptions, right? So there's foundation assistance for that. So just know that even if your insurance doesn't give you the coverage that you might need to afford it, before you accept going without care, explore other resources. There's more available to access. There's money that people and companies are donating to put into these pools. And they're all contingent, right? Of course, it's income based, but I have a great story about my husband's grandmother. She passed last year, so rest in peace. But she had a chronic stomach infection, and she told me, because I said, well, why don't we look into this assistance? She had Medicare, and she couldn't afford it. So why don't we look into this assistance program, because I think you'll qualify. And she jokingly said, I won't qualify. I have too much money. And I thought, let's just try. It can't hurt to try. They'll deny it, right? And lo and behold, she did not have too much money. So they approved it. So even if you think you're not eligible or it's not appropriate, seek the resources and try, and you may be surprised what you qualify for and save yourself a lot of money. Because most people, I know for my family, we have kind of like a set amount allotted each year for healthcare, right? Whether it's through our HSA account or through our savings, that we determine based on the our plan has what's called a maximum spend per year. So once we spend so much, they start covering more. So we kind of use that number to help us gauge like what we might need to have in our pockets in case something happens. But imagine it exceeds that. Most Americans don't have a plan for that, right? They don't have a plan for an unexpected cost that's more than all their monthly bills combined, and now they have to decide if they're going to get their prescription or eat dinner. Yeah.
I know I've been to the pharmacy and they've told me, there's certain discount coupons, like they have some there, or they say go to the manufacturer's website and they may have things there, or ask your doctor about samples, because sometimes they'll have, stuff that they just have available at the office and will be able to give it to you while you kind of work through. Because
yes,
am I incorrect that sometimes this takes a little while, right? You may want to start the prescription now. The doctor wants you to come back in, do labs, check to see if it's working, but you can't because you're going through this process. So maybe using one of those other avenues to get it sooner. Would you recommend that?
I'm glad you asked that. So, couple layers. First, discount cards. They're the things you see on the commercials. Oftentimes, you can use a discount card and get your medication at a lower cost than it would be through your insurance, because that discount card isn't applying your copays, coinsurance, deductibles. The flip side of that is if you use a coupon, you're not putting any money towards that deductible. So depending on what your deductible is, if your deductible is $8 and your prescription's $8, you might just want to grin and bear it and buy it, and then you met your deductible for the year. You'll be saving costs later. But if your deductible is $80 and your prescription is $8, do some mental math, it'd be cheaper to use a coupon that brings it down to $5 and pay that for 12 months than using your insurance that you'll never probably meet that deductible anyway. And sometimes your pharmacy deductible is separate than your medical deductible, so that's something you want to look for too. Sometimes it's combined as well. Just depends on the plan. So yes, discount cards are real. They work. And I think if you're ever in a bind and you want to try them, most retail pharmacies know how to access them or already have them. But if not, Google it. Coupon, pharmacy discount card for drug name X, and things will pop up. Samples are a little less common than they used to be. Drug companies used to bring in abundance of samples to the doctors when they were coming out with new products. It's not as common, but usually if that clinic or provider is frequently prescribing that medication, they'll have some. Or if it's one of those medications that commonly needs authorization, so they're used to their patients saying, I'm going to have a 5 to 7 day delay in getting access, they may have it. So it can't hurt to ask. Like I said, ask. What's the worst that can happen? They don't have it.
Right.
Is there a correlation between an insurance plan's deductible and what is or isn't included in the formulary? Meaning, if you have a higher deductible, will more stuff be included or excluded, or are those two separate animals?
Two separate animals to my knowledge, but I don't work for an employer or an insurance company. But deductibles are typically correlated with premiums. Mm-hmm. So the higher your premium, the lower your deductible, and the lower your premium, the higher your deductible. So typically employer-sponsored plans do have higher deductibles because that employer is trying to save costs on their end for employing their employees and offering them insurance. So, and if you've noticed, those deductibles like just keep getting higher every year, every year.
Similar to homeowner
Yes.
deductibles, especially in
Yes.
South Louisiana.
Yes.
They keep,
Very similar.
yeah, it seems like the costs of everything are going up. For instance, we recently had the flu bug in our house, and we had to get the flu medication. What's it called?
Tamiflu.
Tamiflu.
Yeah.
And it was super expensive. And it made me wonder if the manufacturing costs went up, or if the PBM is just in there kind of hiking the rate higher, or what. But it seems like costs for a lot of different things are just going up and increasing.
I'd have to see the claim to know. But but I will say that the cost is a combination of your PBM's decision and could also include like deductibles and copays. So it might be both, it might just be them, but the PBM is determining the cost for your formulary medications.
And that could be based on availability, like how much is...
It's
like
typically based on like rebate negotiations with the drug manufacturers.
Okay.
Which seems arbitrary.
Yes.
Correct.
Not trying to put a negative spin on it, but it just seems arbitrary that there's a middle person controlling the cost. Right?
And that's why we have people fighting against it. And I do think that we're on the route to getting more transparency. I mean, the first initiatives that are being taken are just let us see what you're doing. Let's just start there. How did you come up with this figure? And then, employers and folks will have the negotiating power to say, hey, we see this and we want to do this or whatnot. But oftentimes they don't even share the information with the employers. So there's times where they don't even know. They just know, okay, this is the agreed rate we're having with this PBM, so we're paying them this, and they're going to manage this, this, and this. And then the PBMs share, they call it, the spread, which is they get rebates from the drug manufacturers, and they're supposed to share those back to the employer, but they don't disclose what the rebate was. So the employer doesn't know like what portion of that was shared. I know that's kind of confusing, but it's just so much lack of transparency. And so they're controlling it and they're profiting from it, but nobody's addressing the gaps that exist. Well, plenty of people are addressing it through the system that hopefully will get some movement soon.
Well, Ashlee, I can tell you, wealth of knowledge, of knowledge. We really appreciate it. Having you on, you've been amazing.
Thank you.
Absolutely amazing. Yeah.
It's really nice.
Yeah, no, it's true. No, we say on our show, tell us something good. Any closing thoughts that are good that you want to tell our viewers and share with us?
Yes, I love that you are making me do that. Because it's hard when you talk about this topic to have to end the conversation and feel good. But there are people fighting. So I was privileged to be included in a health advocacy summit in New Orleans last year. And when I say privileged, I mean, I didn't know how privileged it was to even attend until I got to some of these sessions and heard from some of the people that are doing the work. I was surrounded by thousands of health advocates. These are case managers that work for health systems, clinics, drug manufacturers, pharma. These are people who work in the weeds, and their primary jobs are to help patients get access to care full time. They're overutilized, underpaid, and they're just out there serving. And a lot of what I took back from that was that there's so many more that aren't at this conference that are doing it, right? And you just have to find them. But there are so many resources. There's so many people that want to help you that even though if you leave an office feeling defeated or leave a pharmacy feeling defeated, don't your takeaway should not be, I'm not going to treat my disease, or I'm not going to get the care I need. It should be, okay, I might have to work a little harder for this, but I'm going to get what I need because it's my human right, number one, but also because there's resources out there for me. So I would say ask and advocate, AA, and there is a lot of access to care. Just, I think understanding what you're up against is the first step to being able to combat it.
So maybe as an overview, having a good mindset that it's not I can't, it's I haven't yet, maybe sort of mindset.
Yes.
Okay.
I love that.
Okay.
Yeah.
We talk with our twins a lot. They say, I can't do something. Well, no, not that you can't. You just haven't yet.
Yes.
Right. And I think when the system sort of, in our practice, the system sometimes can seem to throw hurdles or challenges your way. And Carissa does a good job in our office about it, kind of rooting on the team. If you can't get through it, go over it. If you can't go over it, go under it. If you can't go under it, go around it.
Smash the window. Use the sledgehammer through the door.
But I think that's kind of it's the mindset. It's just you haven't done it. You just haven't done it yet.
Correct.
Just kind of be resilient through the system and know that if you believe it, you can achieve it. As cliche as that sounds.
Yes.
Okay.
You are your own best advocate, but I promise you there's somebody else nearby that wants to advocate for you as well. You just got to
maybe ask for the help, because
ask, and if they tell you no, go to someone else.
My mom recently was she had a knee replacement, and so she's been doing physical therapy. Well, all of a sudden, insurance said, I don't think you need that, even though the doctor said
because you're healed.
Because you're healed, right? And so she said, she spent a significant portion of her day calling back and forth, trying to get it approved. And her comment to me was like, what about people that, aren't able to do this? Like elderly, like they don't understand. Maybe they don't have anyone with them. She was really concerned about that. Yeah. And I said, I know, Mama, I think you have to try to find someone that can help you.
Yes.
Right. Like even if you're confused, ask the questions, try,
There are people, and like I said, if you get told no, ask someone else, because maybe that person isn't your advocate or someone who knows. Let me just say, a lot of people who don't know. So just keep asking and keep searching and know that if it's something that you need, yes. Should it be easier to access? Yes. Should what your trusted, physician that you've been with for years, should their recommendation be covered by your insurance? Of course. But in a system that's not designed that way, you just find the loopholes, do the work, and like you said, it's not that you can't, you just haven't yet. Just find the resources.
Yeah. Fantastic. Ashlee Schneider.
Oh.
The cheers.
Ashlee Schneider. Thank you. Thank you so much, Ashlee.
Yeah, thanks for being with us.
I love that I got a cheers at the end.
Yeah, of course.
Makes you feel good. Yeah.
Yeah. Well, that does it for episode 8 of Stay on Track podcast. Our vision is to help 500 plus families battling injuries by year 2028.
And our motto is that we help people who are hurt. Our goal is to earn each client's trust by showing up for them every day. We say here at PO in our office, we say protecting others. And we started this podcast to share knowledge, experience, and insights free of charge to better spread our vision and serve our communities near and far.
For everyone listening in, thank you very much. Please like us and share our vision statement so others may learn more about what we do and who we help. For Carissa and our special guest, Ashlee, I'm Danny. Thank you for staying on track with Poolson Law Firm.
Thank you.